Good afternoon and welcome to session 2B, Substance Use Disorder Current Trends. My name is Charles Searcy and I am the Director of Behavioral Health for Mary Washington Healthcare, and I'm excited to be your host for today's panel. As a friendly reminder, everyone is muted. The last 10 minutes of today's session will be used to answer your questions. Please enter those questions below in the Q&A box at any time. Also, for general comments, feel free to use the chat box. Let's begin with an introduction of our panelists today. First, we have Jodi Manz. Jodi is a project director for the Chronic and Vulnerable Populations of the National Academy for State Health Policy. Prior to working at NASP, Jodi served as Virginia's Assistant Secretary of Health and Human Resources, first under Governor Terry McAuliffe and subsequently under Governor Ralph Northam. In both administrations, Jodi worked across agencies to implement elements of the Affordable Care Act in the Commonwealth, to develop a responsive behavioral health policy, and to coordinate the state policy response to the opioid and substance use disorder crisis. She has a Bachelor of Arts in Religious Studies and a Master of Social Work Administration, Planning, and Public Policy, both from Virginia Commonwealth University, my old alma mater, go Rams. And then we also have Charlie Severance, a policy specialist with the National Conference of State Legislatures. Charlie covers legislative issues related to substance use disorders, suicide prevention, infectious diseases, and other public and behavioral health topics. Prior to joining NCSL in 2018, Charlie worked as a policy and communications coordinator for Live Well Colorado, which is a bipartisan advocacy group that worked to increase access to healthy food and active living. Charlie is a master's of public policy from the University of Denver. Again, if you have questions throughout, please enter those in the Q&A box, and I will turn this over to our esteemed panelists.
All right, thank you so much, Charles. I think we are missing slides. Should I go ahead and share those? There we go. They're just taking a minute, that's all. So while we're getting that together, it's lovely to be on, and thank you to the VHHA for the invitation. I suspect that there are some familiar faces on the other side of the Zoom. Hopefully I've worked with some of you in some capacity in my time in Virginia. For the last 2 years, as Charles said, I've been with the National Academy for State Health Policy. One of the major things that we continue to focus our efforts on is the substance use disorder and opioid epidemic. And I would say, you know, when Jennifer asked if we would speak today in talking about the current trends in substance use disorder, and Charlie can talk about this as well, I really think there are the main trend right now is change. There's change, flexibility, urgency, I would say, are the things that we're really seeing across states. So I'm just going to talk about kind of some of the themes that we're seeing across states and some of the opportunities from up above, from the federal government, and how those might be impacting Virginia. So next slide, please. So just to kind of set the stage, I doubt this is news to most folks. This has been pretty prominently featured in headlines. The overdose fatality epidemic has not slowed down. There are certainly lots of factors for that. There's the potency of the illicit drug supply, fentanyl showing up not just in opioids, but in other substances. There's the impact of the COVID-19 epidemic, which includes, you know, solitary use where people aren't able to be rescued, as well as just the societal impacts of the epidemic and some of the things that has forced. So in the year ending in January 2021, we saw a peak in overdose deaths in the country at over 94,000. That's provisional data, but it's pretty safe to say that we've seen more deaths in that period than we had ever seen before due to overdose. Next slide. And I wanted to drill that down a little bit and show you what this looks like in Virginia. Virginia's Department of Health just recently they released this data quarterly, and it is a quarter behind, but the department does offer projections, and it looks like this year is projected to have the highest overdose level that Virginia has ever seen. Watching these numbers creep up and up and up, is something that is not unique to Virginia. As I showed you on the national slide, these deaths continue to increase, and they continue to increase despite some really good work that's going on and a lot of funding that's been put towards this issue. So we're going to talk about some of the things that might be changing in that space. Next slide, please. So around federal flexibilities for SUD treatment, when the pandemic hit, very quickly, the federal government pivoted and states followed very quickly thereafter. There were all kinds of things that for many years, we wanted to be able to do, including expanding telehealth for substance use disorder treatment and removing some of the barriers to data sharing that can be really challenging for people who are in substance use disorder treatment. And we kind of wrung our hands for years trying to figure out how we were going to do these things, and it turned out that we could do it with just a few waivers and a few changes to major federal regulation. We were able to implement things like telehealth induction of buprenorphine, not requiring someone to have an in-person visit in order to get that treatment. There were also removals of requirements from the DEA for licensure, cross-border. SAMHSA also allowed for longer take-homes of methadone for patients who were stable. That one is still a relatively short period of time, but also some changes around data sharing in terms of allowing non-HIPAA compliant platforms, for telehealth, and allowing clinicians to share SUD treatment data in emergency situations, which, as you can imagine, for patients was very important, particularly as hospitals continue to be impacted by COVID-19. Next slide, please. And this is just, I know there's a lot going on here and you can barely see what's on the right there, but I did want to show how states have responded. Most states have taken up those flexibilities. Some states have pushed to make those things permanent in various ways. Some states are hinging on their own public health emergency authorities in order to do this, or to support the components necessary to do things like telehealth expansion, including cross-border licensure, issues around reimbursement parity for telehealth services. There are also some places, and Virginia is one of them, where there are regulatory requirements that tie buprenorphine regulations to reimbursement. In Virginia, the buprenorphine regulations require that there is an in-person or referral to in-person counseling, require that there are urine drug screens done in order to ensure that someone can continue on treatment. Those are the kinds of things that's very difficult to do in this kind of environment. So there are various moves that states are making in order to either remove those things or to continue hinging on the public health authorities. However, those emergency authorities are expiring over time, or states are not renewing them for various reasons. I did put a link here. I actually don't know if it's live, but there is a link on NASHV's site that will take you to this map that will show you the status of those public health authorities. Next slide, please. So this is just, I think, anyone who knows me knows my favorite policy lever is the budget, because I think that's where you really get the most work done and that's where the rubber hits the road. So the budgetary environment for states around SUD has changed considerably in the last year as well. And that's because the budgetary environment for states has changed. There certainly across states, some states saw an increase in their revenues, some states saw a decrease, most states saw an increase in Medicaid enrollment, most states saw an increase in behavioral health needs, most states also got ARPA funding coming in, and there's also this new component of the opioid settlements that attorney generals are settling with pharmaceutical companies. So overall, taken on balance, you see both some pushes and pulls on state budgets, but overall what you see is an increase in state budget and budget surpluses even in some places. And Virginia has already been through a special session on this. Not all states have. Different states are on different timelines, but figuring out how you're going to use that funding in a way that's judicious and non-duplicative is a major challenge for states. We'll talk about why, I think, on the next slide. Next slide, please. I lied. We'll do it in a moment. But this is just kind of some of the funding that was in the American Rescue Plan. And this is very high level, but there's a total of $4 billion in funding for substance use disorder related services. And that $4 billion is spread across states and spread across programs in different ways. The substance abuse block grants that go to states were increased. There's an increase in funding through the state opioid response grants as well. There's $30 million that was put in the federal budget for harm reduction, which certainly represents a shift in the federal perspective on harm reduction services. The planning grants that were just announced recently, Virginia was not a recipient of those, but planning grants in Medicaid to develop mobile crisis intervention. And of course, the 10% federal match for home and community-based services in Medicaid, which is a pretty big deal. 10% is a good bump. And we're still looking at what those proposals and plans look like. Most of them have not been approved by CMS yet, but there's a lot of new money that's flowing into states through the American Recovery Plan. Next slide, please. So in talking about why is this such an issue, right? Like having lots of extra money to deal with a substance use disorder epidemic that's only getting worse seems like a good thing. It can be like drinking from a fire hose. And I say this as someone who did her best to do this for Virginia for several years, figuring out how to use funds in a way that is going to maximize your opportunity, but also start doing some things that are different. And the pharmaceutical settlements, I think, are probably states' best opportunity to do that. Some of the language in the settlement requires that states be thinking outside the box and be taking some innovative approaches. That funding oftentimes, I think in many states, is going to end up at a local level, but there is a specific amount that is going to be divvied up among state agencies and organizations. But the goal of this is really to eliminate duplicative funding. We have state opioid response grants and block grants that come from the federal government. Those in Virginia are mostly used to fund the CSBs. There are a few one-off projects, but most of that money goes to treatment at a local level. The pharmaceutical settlements give states the opportunity to kind of rethink that and think about different ways that they might want to address things in their states that they haven't been able to do before. In Virginia, I'm sure many of you know, there was statutory language passed this year for the opioid abatement council. I should know this. I just attended a presentation on it yesterday. But in Virginia, there is a dedicated group of folks who will be headed up by the Secretary of HHR, will include stakeholder groups, will include state agencies to figure out the best ways to use this money that aren't just going to go to the same things that we've funded for many years. Next slide, please. The policy environment for states is changing as well. And I think this is really, I've seen just such a change in perspective over the last few years. And I think it is coming from this recognition that on those first slides that I showed you, the things that we're doing are not bringing that curve down. And I think there's renewed interest in things that maybe were kind of peripheral or tangential for a long time. There's certainly a renewed interest in harm reduction. Our neighbors to the north and east in Rhode Island recently authorized safe injection sites. There may still be some federal issues with that, but that's kind of a big leap towards harm reduction. States are allowed to purchase fentanyl test strips with federal funds. There are lots of opportunities, I think, for states to engage in PrEP services to prevent HIV infections. And there certainly is across states, not necessarily in Virginia because the policy just works a little bit differently here, but state policy implications for states that currently don't authorize harm reduction, or they have a statutory limitation on paraphernalia, which would include syringes. There's also a renewed interest in decriminalization. Oregon made lots of headlines a few months ago when they decriminalized possession of most substances and started putting funding towards treatment infrastructure. The issue there, of course, is do you have the treatment infrastructure to actually deal with that? We know that there's a workforce crisis, and it existed before COVID, and it's only been exacerbated since. But there is a renewed interest across states. I think Massachusetts and several other states have recently put in bills and/or passed statutory language to allow for decriminalization. There's also, of course, a renewed interest in crisis intervention. This starts at the top. I know that this has been on the forefront for Virginia for several years. It's also now being heavily pushed by federal initiatives. The goal really is to reduce police interaction and reduce hospital ED utilization. And I think you all are certainly very familiar with the impact in Virginia to having a robust crisis intervention system that would alleviate some of the pressures on the hospitals. Next slide. And then finally, this is one of my colleagues called it the pretty flower slide, but it is intended to show you just kind of some of the complexities that I think exist this is my attempt at making a Venn diagram in terms of the high level challenges for states, despite the funding coming in, despite the changes, I think in the paradigm around substance use disorder, there are certainly many challenges, and none of these are unfamiliar to you. Behavioral health workforce is at the top because we do have a workforce shortage. We have a workforce crisis, some would say. And figuring out how to build that workforce in a way that makes it self-sustaining, particularly with non-licensed workforce, has been a challenge for many states. The prescriber workforce, there's been a rule change that I think Charlie's going to talk about that essentially allows prescribers to not get the Data 2000 waiver to prescribe buprenorphine to under 30 patients. What is that going to look like for states? Is that really helping to build the workforce, or what more do states need to do to continue to build that capacity? There's also the changing illicit drug market, the presence of stimulants, the presence of fentanyl in stimulants, the presence of fentanyl in fake pills. You know, there's also been an increase, like benzodiazepines have kind of always been present, particularly in Virginia's Southwest data in terms of overdose implications. The existing and emerging impacts of SUD on communities of color. We've seen just in recent days some really significant data showing that people of color fared worse in terms of overdoses, particularly during the pandemic. There are all kinds of social implications for that. And what can states do? What can providers do? What can we do from a policy perspective to remove some of the barriers to treatment and remove some of those factors that foster the biopsychosocial disorder that is substance use disorder? And then finally, just a couple of things here that I think are important for states to recognize. One-time funding, like the funding that's coming through the American Recovery Plan Act, requires really judicious infrastructure building. One-time funding is not going to be baked into the general fund. And that means that we have to be very thoughtful about how we use that. Again, widely varying policies on harm reduction and decriminalization. If something is legal in one place and not legal right across the border, we see this in Northern Virginia, or did for many years with DC and Maryland. And when you have those varying policies, that can be very confusing for consumers. It can also be challenging for providers, right? And then finally, widely varying data and data sharing capacities. Virginia has worked pretty hard, I would say, on building out data sharing capabilities over the last few years, particularly around the opioid use disorder crisis. There was a bill a few years ago from was it maybe 2017, 2018 that built out the use case for data sharing around opioids, but it's slow going and it's challenging without ongoing funding. So with that, I will end. Next slide, I think, is just my contact information. This is just where you can reach me. I know we're going to take questions at the end, but if folks have questions or would like to talk offline, this is where you can reach me. So thank you so much.
All right. And I think that we're just waiting for my slides to be pulled up here. But I think that Jodi, you said it quite right when you said that change is really the theme. Obviously with COVID-19, it has been an evolving situation for states in just about every respect, and trying to keep on top of everything that's changed over the last year and a half has certainly been a bit of a challenge. So thank you for that presentation. My name is Charlie Severance. Again, I'm a policy specialist with the National Conference of State Legislatures. And if we could move to the next slide, I think that I've really been asked today to sort of build a little bit off of sort of that overview of the federal changes and national changes that Jodi just talked about, and provide a little more detail about what states are actually doing with those changes to sort of codify them and make them a more permanent part of the legislative or statutory landscape in individual states. Before we get into that, if we can move to the next slide, I do just very quickly want to provide a little background on the National Conference of State Legislatures. We are the country's bipartisan organization serving legislators and staff for more than 40 years. We promote policy innovation, create opportunities for lawmakers to share knowledge, and ensure state legislatures have a strong, cohesive voice in the federal system. We are not an advocacy organization like many of you on the call today, I'm sure can relate to, but we do track state legislative actions. We track the issues state legislators care about and create opportunities to share this information with our members, who we consider to be the 7,383 state legislators across the country and the more than 30,000 legislator staffers who support them. On the next slide, there's a little bit more about our services or specific services to states. We track more than 1,400 issue areas from criminal justice reform, education, healthcare, and transportation to the behavioral health issues we're here to talk about today. The chances are that we have someone tracking that issue and can provide some timely information. NCSL brings together legislators and staff from both sides of the aisle to tackle and discuss difficult problems and find reasonable solutions. We create platforms for leading discussions on some of our nation's most pressing issues by hosting more than 100 policy-oriented meetings during a typical year. NCSL specializes in professional development tailored specifically for legislators and staff, and many of these professional development opportunities are provided at no cost to states. And finally, NCSL works on Capitol Hill on behalf of all states to ensure they have a voice in the federal system. And with that out of the way, on the next slide, I'll transition now into talking about the response state legislatures have had to the intersecting issues of COVID-19 and behavioral health. To do just a little bit more level setting, in 2018 and 2019, many states were celebrating because initial data looked like we were finally coming around a curve. And across the country, it looked like we were finally seeing a decrease in overdose deaths, or at least a leveling off of overdose deaths. Unfortunately, whatever gains we had made at that point in time disappeared in the first few months of 2020. Even before COVID-19 hit, we were seeing increases in overdose deaths, and this trend was only exacerbated as the COVID-19 pandemic escalated. The CDC released some data this summer. Jodi had that slide up that showed about 94,000 people who died of overdose in 2020. And while those estimates are not final yet, they do represent more than 20,000 deaths above the previous high in 2019, and the single largest single year percentage increase on record since 1999. A number of COVID-linked stressors likely contributed to this. We know that things like job loss and financial hardship can exacerbate mental health issues. The pandemic likely made it harder to access naloxone and also made it more likely that folks might be lacking in social support or having someone around who could administer naloxone or call for emergency help if someone was experiencing an overdose. And the other part of the puzzle is that this increase in deaths was largely attributable to synthetic opioids like fentanyl, which was involved in more than 60% of overdose deaths last year. So moving to the next slide, and sort of building off of those changes at the federal level, Jodi had already mentioned, we can get into how state legislators have responded to these sort of dueling epidemics, which has largely fallen into a few buckets. How to connect people to mental and behavioral health care, how to connect folks to harm reduction services, and how to connect folks to naloxone, that all important overdose reversal medication. To get started here, that first bucket I mentioned were state legislative actions to increase access to behavioral health services and substance use disorder treatment programs. This was largely done by trying to increase access to telehealth services. As the federal government relaxed restrictions on telehealth, many states followed suit, including expanding the modalities by which telehealth could be accessed, for instance, dropping requirements in the behavioral health field that providers use video conferencing services and opening up services to phones and other audio devices, but also looking at other issues like issues around initiation of treatment. There's some different regulations at the state level as to how you can treat a new patient as opposed to an existing treatment. So making it easier for those new patients to access treatment through telehealth, issues around psychotherapy, interstate licensing. So if you live in sort of a healthcare provider shortage area in your state, hopefully you can access care from another state, from a licensed provider in that state. And then looking at those issues around reimbursement that Jodi mentioned as well, making sure that private insurers have some sort of requirement to reimburse services at a rate similar to in-person services, but also looking at public programs like Medicaid. So specifically some state legislative action. New Jersey created a bill that mandates that all telemedicine services should be treated the same as in-person visits and paid at the same rate as in-person services. So again, looking at those issues around reimbursement. Minnesota had a bill to include allowing initial evaluations and prescriptions to be completed through a telehealth visit and increasing the number of take-home doses of MAT a provider can prescribe. And in Vermont, they authorize certain health professionals to renew a patient's existing buprenorphine prescription without requiring an office visit. Next slide. State Medicaid programs are obviously a huge part of the care continuum for folks with behavioral health concerns. So as the federal government relaxed some of those requirements around Medicaid services and telehealth, many states, Medicaid is a state administered program, as I'm sure most of you are aware, took similar steps to make sure to codify those changes into state law. So as you can see by the map, at least 15 states as of this summer took specifically legislative action to ensure that telehealth services were covered. This is not an exhaustive look at changes to telehealth and Medicaid. Not every state's Medicaid program needs legislative action or approval to make certain changes, but this is a picture of the states that did. And on the next slide, we've talked a little bit about harm reduction, which was another big concern for legislators during this time. And that included looking at things like syringe service programs or SSPs. SSPs, or at least comprehensive SSPs, are more than just sources of sterile equipment. They are also places for folks to access naloxone, be referred to SUD treatment, get tested for different infectious diseases, or get referred to treatment or get treatment for those diseases, get vaccinated against many diseases like hepatitis A and hepatitis B, which has been a major concern during the opioid epidemic, along with many other services. There are a number of ways states support SSP programs, including going after some of that federal funding Jodi highlighted. NCSL tracked at least 13 bills in 10 states examining the roles of SSPs in the last legislative session, including at least one bill in Virginia. And I mentioned previously that expanding access to naloxone was a key concern for legislators during COVID-19 and since the beginning of the opioid epidemic. This includes some of the work around SSPs that I just mentioned. Those are a great source for some folks to access naloxone. And in this past legislative session, we've seen 17 bills enacted across 8 states that expanded access, clarified Good Samaritan laws, or appropriated money specifically to purchase naloxone. And finally, I mentioned earlier that around 60% of the overdoses observed in 2020 were related to synthetic opioids and particularly fentanyl. So as those particular details made their way into state legislatures, there was an increase in legislative activity examining fentanyl testing strips, with many states looking to expand access to those materials or remove them from state drug paraphernalia laws that might otherwise make them illegal to possess. 7 states since 2017 have exempted fentanyl testing equipment from drug paraphernalia laws or otherwise sought to increase access to that equipment. And now if we could move to the next slide. I got a little ahead of myself with the and finally there. I wanted to diverge just a little bit to talk about the national 3-digit suicide prevention lifeline. As most of you know, this was created through federal legislation. However, there is a significant state component to it. It is a shorter 3-digit number intended to be easier to remember. It sort of models the existing infrastructure that's already in place for the 911 system and takes advantage of the existing infrastructure already in place for the current suicide prevention lifeline. It allows states to impose, but does not require them to impose, a surcharge, which can go to supporting local call centers or to supporting responses to calls to the 988 lifeline. And on the next slide, we've got just a little bit of overview information about the state legislative actions that have taken place in the last legislative session since this bill was enacted at the federal level. 17 states introduced 26 bills. 14 states have actually enacted legislation. Virginia is among them. They've taken a number of different actions, as they usually do. In Nebraska, for instance, they enacted a bill to simply look at this issue and study what is the best approach for Nebraska to implement this program. In Utah, they went ahead and actually created a separate fund and funded that through their general fund without actually imposing a surcharge, at least in this last legislative session. And then obviously I mentioned Virginia has a bill and that was enacted and did actually impose a small surcharge on telecommunication providers. Next slide. And this is really just some trends that we're expecting to see in 2022. A lot of this Jodi has already mentioned. States will decide how to spend money distributed through ongoing opioid manufacturer and distributor lawsuits. The legislature is the appropriations branch of government, so there is an interest in the legislative body to make sure that these funds actually go towards programs that prevent opioid overdose or prevent substance use disorder, and actually go towards the communities that have been most impacted by this epidemic. States are going to continue to grapple with overdose deaths. Naloxone has and will continue to be sort of a key area for states to examine and try to find funding to purchase those programs or purchase actual, naloxone and get that out into the communities and folks who actually need it. And obviously fentanyl testing, we've seen sort of an uptick in interest in that over the last 3 months as that CDC data came out. And I anticipate that in January of next year, when state legislatures reconvene, we'll see a lot more legislative action related to fentanyl testing and making sure that that is exempted from drug paraphernalia laws. Other impacts from the intersection of the overdose and COVID-19 crises. We've heard anecdotally, for instance, that a lot of people who are presenting with COVID-like symptoms and are getting a COVID test actually are diagnosed with acute HIV infection. So there's some fear that we are missing some other health outcomes, and that those are going to start popping up in the years to come. And obviously legislatures will have to be flexible and work around those changes and adapt to those challenges. And then I think the next slide is just my contact information. I think that we have some time now for folks to ask questions, and hopefully we can provide some answers, but you can reach out to me via my email as well.
Thank you both, Jodi and Charlie, for that very important information. So one of the questions that was posed to them are there restrictions on the type of organizations that can apply for the grants, I believe that you mentioned, Jodi?
Those federal grants come down to the single state agency for behavioral health. So in Virginia, those are going to DBHDS. DBHDS then usually divvies them up among the CSBs. So they do go to government organizations primarily through state behavioral health agencies, yes.
There was also somebody had mentioned it's the link is in the public chat section in just regards to information related to COPN requirement changes. So there is a link there from Nathan Kotkamp on that for folks that are interested in looking at changes in COP regulations. See if I've.
Oh, this is great.
Yeah, so just a question that I'm curious just about is along with the opioid use disorder issues, I've seen quite a few reports of significant increase in alcohol consumption and the effects around that. Is there any thoughts about that from either one of you?
I would say, I appreciate, Charles, you raising that. It's, you know, opioids get the attention because the death is immediate, but the drug that kills more people than any other, or the substance that kills more people than any other is alcohol. Alcohol is implicated in so many deaths. I would also kind of take this opportunity to say that almost all overdose deaths are not caused by a single substance. There's polysubstance indicated in the toxicology for virtually every overdose death. And as someone who's worked with folks who are in active addiction or folks who are in recovery, I have never in my life met a single substance user. Most people with substance use disorder will use whatever substance is accessible to them. People have a preference, certainly, but alcohol is one of those things that's virtually endemic as part of the substance use disorder issue. I don't know if Charlie has anything to add to that.
Yeah, no, I would just agree and say, you know, this was also a year in which we saw U.S. life expectancy fall. And I think that ties back to, again, the alcohol use, tobacco use, really just this idea of deaths of despair that we've seen increase year on year since, you know, the late 1990s. So definitely from the legislative perspective, there's a question around what is driving this, and then how do we get ahead of it and sort of upstream.
Mm-hmm.
There's just an update from Marcy about Virginia DMAS is in the process of changing the OBOT so that all patients with any substance use disorder is eligible for that level of service. And again, I'll just mention one more time, there's a link in there and changes in the COPN decisions for hospitals or private providers that are interested in particularly expanding their services or their roles. And there's information there. I don't currently have any other questions either in the Q&A and the chat. I do want to thank both Jodi and Charlie for being here with us today and giving us a lot of information, both at a state and a national level. I think these are incredibly important conversations that we're having. I'm getting information overload today with all the sessions today, but it's a fantastic time, I think, to be around other behavioral health professionals and share that knowledge. So again, very much appreciate Charlie and Jodi, your time today. I didn't know if you had any closing thoughts.
I would just say I think we're in a good position with a lot of work to do, and Virginia I know has had some really significant need, but also has some really significant resources. And right now, I think that you all are headed in, I hope, in the right direction.
Yeah, I'll just chime in and say thank you to everyone for inviting me and being a part of this conversation. I agree with you, Charles, that these are important conversations for folks to be having. And, if there's a silver lining to all of this, I think it is that we were able to get a lot of things done in the short period of time that people had wanted to get done for a long time. So hopefully we can get some evaluation out of that and make sure that, we know if these changes have been successful or not.
And Jodi and Charlie's information is in the chat box there for contact information. And some of this information obviously will be available after the conference from the VHHA. I do want to thank the VHHA for bringing these experts out to us today and to be able to share these conversations. Your next concurrent sessions will begin at 1:45. I want to appreciate both our presenters and everyone who took the time out of their busy schedules to attend today's conference. Enjoy the rest of the afternoon sessions and be well.
Thank you.
Thanks, everyone.
Thank you, everybody, for attending. Hope you have a great day and a great rest of the conference.